Hello everyone, welcome to our second session of Public Health Policy Analysis. Today we begin part one of the course where we'll explore the foundational concepts of policy analysis. Our focus is on policy analysis and the role of government, what it is, why it matters, who is involved, and how it works in practice. This week's assigned readings were designed to ground us both in theory and application. And these two readings provide key definitions and frameworks for understanding policy, as well as a Kaiser Family Foundation briefer on health policy at the federal level. Here's where we're headed today. First, we'll define public policy and the role of policy analysis. Second, we'll ask why policy analysis matters, especially in public health. We'll consider who makes policy decisions, the key actors, both formal and informal. And fourth, we'll explore the criteria analysts use to compare policy options. And finally, I'll present two policy case studies that you'll be working on for your assignment this semester. What is public policy? One classical definition is very simple, that public policy is whatever governments choose to do or not to do. And it's catchy but limited because it doesn't capture the complexity that analysts face. A more helpful definition sees public policy as a set of interrelated decisions made by actors about goals and means, which reminds us that policy is not just about action, it's also about deliberate inaction. The status quo is always a policy option. Policy focus on excuse me. Policy focuses on public problems and the institutional responses to them. Michael Parsons put it well that policy is about the public, its problems, and the ways government addresses them. For example, consider the HIV epidemic. It required coordinated responses across federal, state, and local governments. Yet, at its outset, there are also long stretches of deliberate inaction, which shows us clearly that the status quo is a policy option, similar to the COVID-19 pandemic. This is a list of 10 actions that governments can do, and these are the bases of policy, so please do familiarize yourself with them. Public policies come in many forms: the Constitution, formal laws, regulations, and budgets passed by elected officials, guidelines and internal rules within agencies, and even deliberate inaction on pressing issues. We'll see examples in HIV, such as the Ryan White Care Act, and federal funding streams and agency level guidelines, for example, from the CDC or the Health Resources Services Administration. It's important to think of policy not as a constant, but as a variable itself. Policies shift over time in response to evidence, politics, and conflict or context. And with HIV as an example, funding priorities have evolved from emergency response in the 1980s and 1990s to long-term management today, showing that this fluidity is why policy analysis is so critical. Analysts help navigate shifting priorities and contexts. Here we make a key distinction: policy and politics. Policy is the substance, which are the actual decisions, laws, programs, and funding priorities, whereas politics is the process, how those decisions get made through negotiation, conflict, and compromise. Theodore Lowy argued that policy determines politics, the means of content of decisions, like whether to expand food assistance programs, shapes which coalitions form and which actors gain influence. For example, the content of a policy decision can help predict who the most influential policy actors and choosing the preferred policy or course of action would be. Policies don't just reflect politics, they also reshape it. This dynamic interplay between policy and politics is central to analysis. Different power imbalances between policy actors under certain contexts and within certain processes may change if a policy changes any one of these variables. Now, narrowing in public health policy includes the courses of action and inaction that shape health institutions, organizations, services, and funding. Some policies define agency powers and responsibilities, others aim directly at the protection and promotion of health. We can group public health policies into two categories: those that define functions and powers of agencies, and those that directly protect or promote health. So you can see that laws, agency regulations, and court decisions aim to address both of these groups, while clinical guidelines, hospital or clinic policies would aim to promote or protect health and don't themselves define functions or powers of health agencies. So, why do we need policy analysis? Because public health problems rarely have simple solutions. Policy analysis uses evidence and reasoning to compare alternatives and recommend the best course of action. Think of HIV testing strategies or access to pre exposure prophylaxis, which prevents the transmission of HIV. Data driven policies in these areas have dramatically improved outcomes. The Institute of Medicine has long recognized policy development as one of the essential functions of public health. And as HIV has shown, effective policy emerges when science, advocacy, and institutional capacity come together. The HIV epidemic also showed us why public health policy matters, because it's about preventing transmission, ensuring equitable treatment access, integrating long-term care for a chronic condition, and tackling stigma, which remains a major structural barrier. Let's go back and recall the context of the HIV epidemic. The first case in the US was reported in 1981, and throughout the 1980s, the governmental response was slow, marked mostly by inaction. It was grassroots activism that forced urgent policy responses, and this history teaches us how vital community action can be in shaping public policy. Groups like ACT UP reshaped the policy landscape. They fought to speed up FDA drug approvals and redirected NIH research priorities to investigate HIV. Their activism illustrates how informal actors outside government can be pivotal in policy change. HIV also highlights systemic inequities. Disparities in race, gender, sexual orientation, and geography mean not all groups experience policy equally. That's why an equity lens is fundamental to effective HIV and public health policy. Local policies can also lead the way. For example, in New York City, the government established a dedicated HIV/AIDS bureau before most other states and cities, which shows how local innovation can fill federal gaps and create models for others. Globally, UNAIDS and WHO have set the goal of ending AIDS as a public health threat by 2030. This reminds us that HIV is not just a US issue, it's a global health policy challenge, and the highest burden of HIV is in sub-Saharan Africa, where many innovations are made both in policy and medicine. Who makes policy? The term policy actors covers a wide spectrum. This includes legislators, agencies, advocacy groups, media, universities, and other communities. Each play a role in shaping both the process and the outcomes of policy. Formal actors include Congress, HRSA, and the CDC at the federal level, as some examples, Medicaid agencies and health departments at the state level, and dedicated HIV service offices at the local level. Informal actors include advocacy organizations like ACT UP, professional societies such as the American Medical Association, and the media, uh, which is a broad spade of organizations and perspectives which can shape public narratives and political pressure. Coalitions have been critical for sustaining programs. For example, the Ryan White program came up for reauthorization in 2013. Broad advocacy coalitions lobbied Congress successfully to ensure its continued funding. Franklin D. Roosevelt once said, "You've convinced me. Now go out and make me do it," which underscores the reality even when leaders agree. Sustained advocacy is needed to move policy forward. Decision making is no longer confined to bureaucracies. It's dispersed across many actors, adding both complexity and uncertainty. So let's walk through the criteria one by one. Effectiveness does is asks what does the policy um, achieve, and does it achieve its intended outcomes? In HIV, we measure effectiveness through indicators like reduced transmission, higher retention and care, and viral suppression rates. Another criterion is efficiency. Are the benefits worth the cost? For example, the Ryan White program is efficient because its costs are far outweighed by savings from avoided hospitalizations and improved health. Equity asks who benefits and who is left behind. A good policy reduces disparities rather than widening them. And it's important to remember that equity is not the same as equality. Equality means that everyone gets an equal share, and equity means the share of resources are distributed in a way so that equitable outcomes um, exist. In HIV, this means focusing on groups historically marginalized from care. Political feasibility matters, and it asks, can the policy actually be adopted and implemented? For example, the Ryan White program is a stronger example because it has maintained bipartisan support for decades despite gridlock and political polarity in Congress. Finally, impact asks about the broader contributions to public health. Does the policy reduce stigma, for example? Does it strengthen health systems? Does it improve the quality of life for people beyond its immediate goals? So, this brings me to your case studies. For your assignment throughout the course, you and a partner will choose between two case studies. First, the Ryan White HIV/AIDS program, or second, policies to improve long-term well-being for people living with HIV. Ryan White, the Ryan White program was established in 1990 under the CARE Act, and it remains the largest HIV-specific federal program and serves more than half of the people living with HIV in the United States. Particularly, it covers those who are uninsured or underinsured. In the fiscal year 2024, its budget was more than $2.5 billion, and it's the third largest source of HIV funding outside of Medicaid and Medicare. It provides outpatient care, medications, and funding for case management. It's structured into 5 parts, from funding the cities and areas that are hardest hit by the program to supporting um, women, infants, and youth, and then uh, part F includes dental training and the Minority AIDS Initiative. These bullet points represent its clientele. This is who the Ryan White population program serves, more than 500,000 people, most of whom are people of color and live below the federal poverty line. Nearly 20% are uninsured, and almost half are over the age of 50 years old. Over half are gay or bisexual men, and women and transgender people represent less than a third of its clientele. Outcomes are strong. Viral suppression rates are 91%, which compares to 65% in the US average. And it's also been shown to reduce racial disparities in health outcomes. For example, a modeling by Goyle in 2024 estimated a 99% reduction in racial inequity in viral suppression over 10 years. Beyond care, Ryan White supports housing, transportation, and behavioral health, including the social determinants of health. It's central to the federal Ending the HIV Epidemic initiative, and aims to improve care retention across the HIV care continuum. Challenges do remain, however. For example, funding doesn't always keep pace with the need, and clients are aging with complex comorbidities, which we'll touch on in the next section, and it needs better integration with Medicaid and the Affordable Care Act. So the second case study will look at viral suppression issues. Issues beyond viral suppression. These began in earnest in around 2015, 2016, when countries and researchers were noticing that people living with HIV were living longer, almost nearly as long as those without HIV, due to improved antiretroviral therapy. And in 2016, Lazarus and other researchers proposed a fourth 90, which looked at issues beyond viral suppression and focused on achieving a good quality of life after viral suppression. So if adopted, these would extend the national goals beyond suppression alone. Currently, national goals are that 95% of people living with HIV know their status. 95% of those who know their status are linked to HIV care, and 95% of those on treatment or in care are virally suppressed. So this new fourth 90 would go beyond viral suppression. People with HIV are living longer, but often with multiple comorbidities, including cardiovascular disease, cancers, renal or liver disease, and depression and other mental health issues. Policies, however, have lagged in monitoring and addressing these needs. Unlike the other indicators on the HIV continuum, and certain diseases like tuberculosis, HCV, and AIDS-defining cancers. Beyond viral suppression, requires integrated, multidisciplinary, person-centered care, and also includes addressing the effects of stigma and causes of health center-based discrimination. The long-term success framework proposed by Lazarus includes 5 pillars: that people with HIV have a sustained undetectable viral load, that they receive a minimal treatment burden by the health system, their quality of life is optimized, and that they receive lifelong integrated care with freedom from stigma. Challenges include lack of standard quality of life metrics, including gaps in fragmented systems, and quality of life evidence shows that well over a majority of people living with HIV over 65 years of life have multimorbidity, that is, 2 or more conditions besides HIV, and that this multimorbidity lowers health-related quality of life. Stigma, poverty, and isolation are also key drivers of low quality of life. Health systems should collect patient-reported outcomes, standardize quality of life monitoring within this population, and integrate HIV and other chronic disease care to better inform their decisions about care for people living with HIV. Equity in aging with HIV include policies that address frailty, poverty, and social exclusion, as well as stigma and housing instability. Here we see the global HIV targets framework, which puts people living with HIV at the center. Around the circle, you'll notice several 95% targets. Again, that 95% of people living with HIV know their status, 95% of those who know their status initiate treatment, 95% of those on treatment achieve viral suppression, and 95% of women should have access to HIV and reproductive health services. 95% coverage of services should eliminate vertical transmission of HIV from mother to child. And 95% of people at risk should have access to combination preventive strategies. Together, these targets reflect a comprehensive approach that goes beyond just treatment. It also emphasizes prevention, reproductive health, and equity of access. On each side, you'll see additional commitments that less than 10% of countries should maintain punitive laws and policies. Less than 10% of people should experience stigma and discrimination, and less than 10% should experience gender inequality and violence. Finally, 90% of people living with HIV or those at risk should be linked to people-centered, context-specific integrated services. This slide shows key challenges for HIV policy. We still lack standard measures of quality of life, face funding gaps for support services, and continue to struggle with stigma. At the center is the need for sustained advocacy, which is essential to keep these issues on the agenda. In conclusion, the Ryan White program illustrates how policy can create access, equity, and strong outcomes, while the long-term well-being case shows the need to expand our policy goals beyond suppression to quality of life and healthy aging. Together, these cases demonstrate policy analysis as a tool for equity and sustainability in HIV care. Before next session, you should review the discussion board to select who you would feel most comfortable partnering with on one of these case studies, and discuss which case study you'd like to partner with. At our next session, we'll turn to the social determinants of health, which builds on today's discussion of actors, equity, and context. Thank you.